So it is 12:06 on 5/27. So good news I was just telling you guys is the job market's starting to pick up. We've had a lot of jobs come across the desk recently, and I just got 5 more that I have to post. So I'll be posting those shortly. And the other thing I'm noticing is I was thinking with the pay differential cut that the salaries might go down, but it looks like the salaries overall have stayed flat. So it's not like they've gone down or really up at all. So we'll take it. Let's start today. We'll start with the musculoskeletal review that I had planned, and then we'll do my neuro review quiz. I have about 30, 35 questions. And then we'll go into the Q&A if anyone has anything. And if anyone has anything they want to cover, drop it in the chat box. That way I can go back to it and kind of hit it at the end. But let me share my screen here and bring up our Slido. All right, there's our Slido brought up. I'm gonna probably bring this full screen. You guys can, that way it's nice and neat for you guys. Let me bring my chat box up, but I'm gonna bring it up in the corner here so it's out of my way. Everyone see the Slido there? Is it allowing you to join? Did I freeze? Okay. Turn my volume up. Why is it not letting me go forward here? Oh, I gotta click play, that's why. Activate quiz. That would probably help. Now, no, go back. Stop. I do not want to activate the quiz yet. Hold on. You saw the preview. Stop. Present in a new tab. Slido is being weird today. There we go. Oh, it's still going to do the first one. Oh, well. We'll just go with what we got and pause it after this one. That seemed that went really fast. Hold on. Nope, it was 45 seconds. That just seemed to go really fast. No one even got to put one in. Why is it? Where are my controls at here? Hold on. Slido is being a pain in the butt. Let me stop share real quick. And why are my controls not here? Give me 1 second. All right, let's stop. And we'll that, and then we'll share it, present a new tab. All right, so we got people join now. I figure out why I have no Slido controls. Just give me a second here. It's being finicky for some unknown reason. Let's reset results. And so no participants yet. Now we'll all right, so you guys are joining. is it not giving me my controls? Give me 1 second. You guys are all in. It's just being really finicky about the controls. I'm trying to figure out why. All right, well, let me try starting the quiz and see if that works. All right. I'm not sharing the screen. That wouldn't help. Slido's being finicky today. I apologize. I still have no controls. This is acting weird. Well, we got this question down pat at least this point. Give me 1 second. Always get technical issues with Mr. McKeever. I'm hosting it. You guys are in it. Give me 1 second. I'll try one more thing. So I can do the correct answer here. We got the question right, at least. This is weird. Okay. Try one thing here. Maybe it's just the screen size. Because used to my big monitors at home. Settings. Give me just 1 second. Don't need live polls. Oh, there's present mode. Okay. All right, let me try. So I'm going to try one of the other quizzes real quick and see if it's just this one acting up. So hold on 1 second. I wonder if it's because I have all the other ones active. Give me just a second. This is weird. All right, so I have to control it from one screen and go to the other one. Okay, whatever. We'll make it work. So present. And All right, so I'll share screen. I just have to go back and forth between going to the next section for some reason. Whatever, we'll make it work. All right, so yes, decreased deflection. You guys got that one right. Let's go to the next question. Leaderboard, should go to the leaderboard then. I know what it is. It's because I'm not on two screens. Next question. Here we go. I'm going to cut out all the error. Made me look like I'm silly. Diana's got a very shiny background today. All right, let's see what we got here. So that's done. It's given the results. Maybe. Come on now. You can do it. Results. All right, so we're split between those two. And the correct answer is resisted flexion of the NTP joint. So let's think about it real quick. So it's talking about lumbricals, right? And we talk about the arch, it has to be like this, which means the toes have to move into flexion, right? If you go up, you're actually going to do what to the arch? Does anyone have an idea? If you do extension, you're going to flatten that arch out, right? Yeah. Good. All right. So toe scrunches. Yes, exactly, bro. Toe scrunchies. Leaderboard, and then next question. All right. All right, so we got two different answers. We got obviously coronal and transverse. The correct answer is transverse plane. So remember, all rotation, right? All rotation is transverse plane whenever you get a question on your boards. So all is, and the other thing here, real quick, why should you not pick coronal? Anyone have an idea? Yes, frontal and coronal are the same thing. Exactly. Yep. So you can rule them out. So it'll either been sagittal or transverse. And what's sagittal motion primarily?
An anterior to posterior.
Anterior to posterior. So flexion extension. Good. Yep. You got it. All right. Let's skip the leaderboard and go right to the next question. Okay, good. Now, I will say that was good, excellent. Y'all picked it, right? I will say that Dr. Reskin would have a slight problem with this question because she'll say that this is a little too much diagnosing, right? So what I would say to that is with this, you're not diagnosing so much as making an assumption of what you're looking at or conclusion so that you can go and tell who?
Your PT.
Your PT, good, right? Because that'll help them at least and say, hey, you know, I think this patient has XYZ. Can we take a look at it? Right? That's the main idea there. It's not necessarily that, you know, we're not saying, oh, well, they have this problem. We're just looking at it going, hey, I think they have this problem. So can we take a look at it? That's the main idea there. All right. So can I go forward here? One second. All right, next question. This one's a hard one because this is a prosthetic. That's what I kind of expected us to be kind of all over the place. So what this is saying is patient with an above knee prosthetic, right? Places the prosthetic foot either medially or laterally during heel strike phase of gait and reports it's difficult to control its placement. So the main thing here is we're dealing with the actual control of placement, which means we need a controlled activity, right? So when you're looking at the questions, you want to be thinking if you see a thing where it says controlled activity, your brain needs to go down and look for something that is an activity that involves control or very specific, precise movements. Does that make sense? Right? So controlled tap in a prosthetic in a colored circle while standing would be the controlled activity. All the others would be really good strengthening activities, right? But this isn't necessarily a strength problem. This is a control problem because they have a prosthetic. So the control problem is the better answer there, right? All right, let's go to the next question. I found I can control it from my phone. There we go. You guys better get this one. I'm going to scream. All right, so when they say graded oscillation techniques, what's that the fancy word for?
Joint mobilization.
Joint modes. Yeah, it's just a fancy word for joint modes. Good. Right? And if you remember, I have good English. Joint modes, grades 1 and 2 are pain modulation modes, right? What are grades 3 and 4 for?
Is it range of motion and stretching?
Yeah, range of motion. Yeah. So, well, we're going to stretch the capsule, which is going to give us range of motion. Good. Right. And then if there's any questions about us performing a grade 5, what's your answer? No, yeah, no, exactly. Only PT. Good job, Alex. Excellent. All right, let's go look at the leaderboard here. It's a thrust, exactly. And we don't do no thrusts, we're PTAs. Now that I read this question, I don't like it. Yes. Okay, so we got pretty much it's tied two answers. So the best answer here is strengthening. But as I'm looking at this, I could also see strengthening of the quadriceps. So when I'm looking at this question, if my problem is from heel strike to foot flat, then the strengthening is going to be of the glutes. If the problem says I'm still leaning posteriorly during, mid stance through toe off, that would be more strength of the quadriceps. So yes, the question's right, but also I'm looking at it going, I don't really like the full question. Had some good scores going today. And yeah, Joe, extensors would be kind of glutes on the same level. But extensors would also include the hamstrings then. Good. Good. I only threw at least one E off there, right? So anytime we have tight hip flexors, right, we are going back to, if you can't think of what it is, draw the diamond, right? So we have your hip flexors, your hip extensors, your trunk flexors, and your trunk extensors. And then if you shorten it up, what happens? You get a lordotic curve in the low back. So good job. I'm performing the last one while we're sitting here. You just can't tell. I'm just joking. Okay, so we're either one or two. Good. I'm happy about that at least. The main reason one is the best answer is because it's going to give us the most range of motion, right? So if there's my knee and I put a towel roll down here, it gives me more room to go down. Now, isometric quad sets with a pillow under the knee, maybe once we get kind of a little bit more strength, then we can use that kind of as resistive activity. But the towel roll under the heel is the best option there. And no one picked the glute sets, which I'm glad because the glutes had nothing to do with it. Right? That was just a butt of a joke there. We're missing the music from Kahoot. All right, good. All right, so we have two different answers. Those are two I would pick between, right? Because if it's spinal disc herniation or spinal segment instability, it's probably only going to be a single or maybe a double spot fusion, not a long spinal fusion. And long spinal fusions are primarily in scoliotic curves, right? That's where they're going to literally go down the spine and just fuse it the whole way down. I'm going to bring myself down a little bit. So good. Starting to think some of you might have seen some of these questions before. I don't think I used these before, but maybe I did. Okay. Don't get this one right. Dr. Reskin's going to be very mad at you. And I'm going to tell her. Just saying. I'll rat you guys out. Oh, God, I don't have to rat you guys out. Good. What are the two groups of intrinsics? We got the interossei and then the lumbrical. Lumbrical. Good. Go forward. There we go. All right, here we go. You guys are doing good on this. This is scaring me. All right, good. So we're in the general vicinity, right? The inferior capsule would be the best answer there. And can we really separate when we're stretching? Can we separate out pec minor and pec major? Not really, right? Good. So what would be the stretch we'd use for that?
Doorway.
Doorway stretch. Good. Yeah. Right. And horizontal abductors, we'd stretch across like this, right? So a cross body stretch. And that would actually stretch. So which capsule would that stretch coming across like that? Posterior.
Posterior.
Yes. Yes. The MDT should be the clue. You know, the way you guys are doing, you should feel good about this quiz. Okay, so what's the MDT stand for?
I actually don't know what that is, so
Okay, good. That's okay to ask. I'm going to say Dr. Reskin taught you it in PTA 207. You might have been taken aback by it.
I know it has something to do with POBAF, but I can't remember.
No, McKenzie. There we go. McKenzie diagnostic technique. Good. Right. So MDT, anytime you see MDT, it's McKenzie diagnostic technique. Right. And so the progression for MDT is prone lying is first, right? And then POE, prone on elbows, right? What comes after that?
Press up into extension.
Yep. Prone press up into extension, and then extension in seated, and then extension in standing. Extension and standing is always the last part of the McKenzie diagnostic technique.
What does SXS mean? I don't know why I didn't get that.
That's okay. What's that mean? Symptoms. Yeah, there we go. Sorry, I ran out of space in typing, so I have to abbreviate some of it because you're only allowed so many characters.
Okay, and this is just the 4 things, like the 4-way, what you just said?
Yep. Yeah. So McKenzie starts with, like I said, prone on elbows, prone press up, extension and seated, and then extension and standing. Why would extension and standing be the last one? Full weight bearing. Good. And stability. Yes. Right. Because we got to build up the stability before we get up to full weight bearing. Good. Right. And for the most part, all of our progression techniques of all of our exercises, standing is the last kind of position we do the exercises in. Right. Think about even like the 4-way hip. The 4-way hip, we kind of start in supine and we don't ever get standing until they've got full kind of balance and stability. So good.
What about they don't have a lot of stability, but they start at the parallel bars?
You still, I mean, still standing is going to be the last kind of technique for it. When it comes to McKenzie, standing is always the last one.
Okay.
Does that make sense? Okay. All right. Next one. I'm staring at you guys here. I'm just going to sip my coffee. Uh-oh, I'm sorry. Can you at least still see it, Riley? At least so we can review. Okay, good. At least that you can see it. That's the important part. I mean, I don't care about the scores, to be 100% honest. That's just on you guys. All right. So I'm going to make some of you mad here, I'm pretty sure. So remember, with this one, the most commonly fractured human bone is the clavicle. The most commonly fractured adult bone, specifically in what type of an accident? Foosh, yes.
Fall.
Yeah, fall is scaphoid. And then a most commonly fractured bone in somebody 65 and older is the femur. So none of you picked that, the femur or the hip. Yeah, exactly. Good. So clavicle is always the most fractured. And the main thing I think about when I think about that is I just think of Aaron Rodgers because he just can't stop fracturing his clavicles. Ooh, I see good numbers here. Okay. 3 is the right answer. Why is 3 the right answer? What are you lacking in number 3?
Dorsiflexion.
Dorsiflexion, yeah. Right. So it's saying which of the following cause problems with the patient during walking, basically. 0 to 110 degrees knee flexion, we're golden. They can even go up and down stairs. 0 to 90 of hip flexion, while still limited, that's enough for walking, right? What do we need for walking in the hip flexion? Do you remember? 60 to 65. We can go over the concept of the lag. Thank you, Brooke. Just I'll remember that. It's on the chat so I can remember it. And then 0 to 15 of hip adduction. In reality, do we need even 15 degrees of hip adduction? No, right? So that's just a red herring out there. And just remember, red herrings are fish and fish are smelly. Don't go for them. Next one. I know this one's a tough one. Not good with hands. I don't know. You guys did okay with hands. I mean, I saw you doing exercises and massage. I'm funny. Okay, good overall picks. So trapezium is the best answer here, right? And with the capitate, one thing to remember is capitate kind of moves with most stuff, right? The capitate's one of our bones that's responsible. Yeah, hey, good, you guessed right. Excuse me, the capitate's one of the ones that helps create the pulley system in the hand, right? For which muscles, the flexors or the extensors?
Isn't it the extensors?
The extensors, yeah, right? Because primarily the capitate pops up in the back of your hand. And then with the radius, well, the radius is kind of not going to articulate with the, radius articulates with lunate because it's in the same row, right? Capitate's kind of there. And scaphoid, obviously, okay, some lovers, right? Try positions that they can't handle. Remember that old adage? So again, are you going to get all hand questions? Probably not. All right. So the best answer there is blood test, because what is rheumatoid arthritis considered?
Autoimmune.
Autoimmune, good, right? And we need the ANA test, the antigens and antibodies test, in order to determine if they've actually got it. And again, that's for a definitive diagnosis. Yeah, rheumatoid factor assessment. Yep, you got it, right? Because ANA and a couple others are in there as well. Now, joint symptoms would clue us into maybe them having some rheumatoid arthritis, but the definitive diagnosis would definitely be a blood test. Painful point profile. What are we using that to diagnose? You guys remember that one? We're ruling it in or ruling it out, Brooke. Nope, not sensation. It actually is a disorder. So this is the 13 painful points on the body. That's what the painful point profile is.
Fibromyalgia.
Fibromyalgia. There we go. Good. Yeah, that's the fibromyalgia test. I can go over rule in, rule out too. Sure, we can do that. All right, we got like 3 more in this one. Better get this one right, or Mr. McKeever's gonna be mad. I hear he gets angry with questions like this. See if they tricked anyone. They didn't trick anyone. That's good. That's why I threw it up there, Anthony. That's why I said I didn't trick anyone. Right? So the key there is least appropriate, right? If it said most appropriate, Anthony, you're correct. Parallel bars is the way to go, right? I threw this one up there on purpose because I was seeing if anyone would go for parallel bars. Now, rolling walker is a good choice, but rolling walker at least gives them some protection laterally so they don't fall, right? Single point cane is our least stable and probably should not be given to somebody with osteogenesis imperfecta. What's the other term for osteogenesis imperfecta? Brittle bone. Good. All right. Yes, Mr. Glass. All right. So this is really nothing more than a kind of redux of the question we had a little bit ago, right? Where it asked about if you have tight quads, if you'd end up with a severe lordotic curve, right? So the hip flexors are what's going to cause a lordotic curve. Hamstring tightness would cause what to happen to the low back?
Stretch.
Yep. Okay. It's stretch it out. So you'd have flat back or sway back, right? That really kind of flat, either sway or flat back are the two you get, right? So if you get that really flat back, that's what we do when we do a posterior pelvic tilt. So iliopsoas, although I would say that iliopsoas tendon lengthening is not going to be very fun for that kid.
I think this is why I keep getting confused because I'm thinking I'm going back to anterior and I'm thinking of anterior pelvic tilt.
Yep. So anterior pelvic tilt would cause the lordotic curve.
Yeah, but that's what I keep thinking because when you have an anterior pelvic tilt, your hamstrings and abs are they're weak.
Yep, it could be. Yes, it could be very weak. Yes. But tendon lengthening is not going to help you with that, right? Tendon lengthening is actually going to make the muscles weaker. Does that make sense? Because what are they doing with tendon lengthening? They're literally going in and doing what?
Lengthening them even more, stretching.
Not even stretching. They're going in with about a 10-blade scalpel and making micro cuts in it. And then stretching, which would be real fun, Riley, right? So they've got the person out, they're pushing down, the doc's sitting there cutting as they go through it, and they're stretching as the doc cuts, which I'm sure feels fantastic. All right. I think this is the last one for this one. Okay, so far we're split. Oh, now we're really split. Oh. Okay, let's start at the bottom and work our way up. What is Faber? What are the three motions for Faber?
The hip flexors.
Yes, so flexion, abduction, external rotation. It's right in the name, right? The Faber test. Over, the leg is going over the other, so that is for what?
The IT band.
IT and TFL, good, right? And then we're down to Homans and Thompson. So those would be the two that we could get stuck between for a ruptured Achilles tendon. But Homans test is the test for what?
DVT.
DVT, good, right? And then Thompson is the test for Achilles tendon rupture, right? So Thompson is where you squeeze the gastroc, and if you squeeze it, you should get plantar flexion. But if it's ruptured, nothing happens. That's okay, Brooke. That's why we do this. Go forward to results. Congratulations to Lemon's disease. So very good overall. I'm looking at this going, those are some good scores. Lemon's own lines, right? I love it. But those are some good scores. So you guys, good. Feel low-key happy is okay, right? I mean, in general, we did pretty good. So let me stop sharing of this one. So good job overall on those. That was, yeah, that means you guys studied a good bit for that one. So let's finish the quiz out. And we'll go back. And before I start the next one, let's hit the topics that we had questions on, right? So going up, the first question we had was on lag, right? Oh, I missed the question, Anthony. Yes, that could cause steppage gait. I missed that question. I'm sorry. So let's talk about lag first, right? Whenever you see lag, right? Lag means it is missing whatever. So if we have extension lag, it is missing extension. If you have flexion lag, you are missing flexion, but that almost never happens. But right, if you have flexion lag, you would technically be missing flexion. So anytime you have extension lag, it means the knee. So typically extension lag is what you're going to see. And if I have extension lag, that means my knee is always in a slight bit of what?
Flexion?
Flexion. Yep. Yeah. Good. And that, yes, typically happens kind of at the end range. Yeah. So it's very rarely they're going to have like 90 degrees of extension lag. That'd be really bad. They'd be stuck in 90 degrees of flexion, right? So in the case of that one question where it was saying the patient was, so here's my ankle, right? So I should sit at kind of neutral, which would be technically a 90-degree angle, but it should be kind of neutral here. The question said the patient was stuck at 10 degrees of plantar flexion and could go to 45, but they technically had 10 degrees of plantar flexion or of lag of going into dorsiflexion. They couldn't even get to 0, so they would never clear their foot walking. So that would be the problematic. And then we had the question.
And is that foot drop?
No, well, I mean, could be. That we would have to research a little bit further, Brooke, to see if it's the dorsiflexors that are a problem or if they're just super tight in the plantar flexors. Right? It could be one of those two things that could be happening there. And that'd be where we'd have to figure out which is the chicken and which is the egg. Because technically, if we're stuck in plantar flexion, eventually the dorsiflexors are going to shut off. Right?
Mhm.
And then we would definitely start getting foot drop.
Oh, okay.
Does that help?
Yes.
Okay.
I get confused too when it's like, say it's like 15, 0, and then like 130. I haven't gone over it myself, but I just, since
Okay.
it came up, if we could go over it.
Sure. Right. So if you have a measurement that says 15, 0, and then whatever, she used 130. So we use that, right? So that means, and typically the only time you're going to see that is in a joint that has both extension and flexion range of motions. right? So like the shoulder, if my reading said 15, 0 and 130, oh, we didn't lose Brooke now. Okay. I don't know who we lost. We lost somebody. That means I go from 15 degrees of shoulder extension to 0 to 130 degrees of shoulder flexion. Right? That's when we, and again, we're getting kind of away from using that nomenclature where we now just say, here is the shoulder flexion range of motion, here is the shoulder extension range of motion, which is the way most of the new goniometry books are saying, because of the confusion, Brooke, of if you add that 15, 0, 130, people are like, what? And it was even more confusing back when I went through school and it was like negative 15 to 130. I hated that. Right? But if you see 15 and then you have a 0, that means that the person's going past neutral to whatever that is. If I had the elbow extension and it said 15, 0, 130, that would mean my elbow has what?
Like hyperextension?
Yeah, hyperextension, right? So that would mean that I've got that good old weird elbow. I don't remember. One of you guys had pretty bad hyperextension when we did the measurements. So that would mean that we'd have really bad hyperextension. Exactly.
So we can likely see that still on the test with the 0.
I mean, you may, but I know that most of the, like I said, most of the books are moving away from that. So it'll probably say that your patient has 0 to 30 of shoulder extension, right? Or 0 to 180 of shoulder flexion. But the only time I've seen a question recently on that is when it's talking about the elbow, and it'll say like 5, 0, 135, and it's asking you, what is that considered when you have that 5 degrees? And that's hyperextension, like you answered.
Okay, that makes sense.
Yeah. So the main ones for the most part are just going to be going between the, telling you which one's which.
Okay. Thank you.
Yeah, no problem. All right. Any other ortho questions? Oh, wait, we did have one. We had, I forgot, we had the whole rule in, rule out thing, right? Good. All right. So rule in, rule out is when we're dealing with diagnoses, right? So if it's just asking, which is the definitive test, it's just asking the best test. That's all definitive means, which is the best test for X, Y, or Z. And like I said, with the question about rheumatoid arthritis, we know rheumatoid arthritis is autoimmune, so it has to be some sort of a blood test, right? For osteoarthritis, what would be the kind of definitive test for osteoarthritis? What do you think? MRI or, yeah, we'll just go with imaging in general, right? Good, Riley. Any form of imaging in general would be the kind of default for that. Could be an MRI, could be, I mean, some doctors still go x-rays, but they don't always show the best, right? So some form of something like that. Then when we talk about rule in, rule out, that's when we're picking the best test, right? And that's where we get to our two abbreviations, SPIN and SNOUT. Remember those? So if that's where we get to specificity and sensitivity. Specificity is to rule a test what? In. Good, Anthony, right? Sensitivity is to rule the disease out. So I'm going to use the at-home COVID test as a great example of this. The at-home COVID tests have a specificity of about 60 and a sensitivity of about 45. Right? So that means does that mean they're a really good test? No, Jason's shaking his head no, right? They're an average test. They're good for something at home, right? If you want just a quick test to see if you actually have maybe a condition, right? It's a good quick test at home. Obviously, going and getting the PCR test is your best option because that has a real high specificity. It's like 0.95 on the specificity scale. So that means if you go and you get the test and it comes back positive, you got COVID, right? But it's not got the best sensitivity. I think it's still only like in the 60s for sensitivity. So if you get a negative, you may not have COVID, but you may, right? They're not 100% sure at that point. So specific SP, right? So when we deal with that, so SP, right? So SP, there we go, spin and snout. Specific test with a positive result, rule the condition in. Sensitive tests with a negative result, rule the condition out. Does that help, Brooke?
I think so. So if we're ruling in something and we want to know if like the test, what test is best, ruling in, I would choose specificity, the highest number.
Yes, exactly.
Down the
Yep.
list. Okay.
And then if it said to rule something out, you'd want something with a high sensitive number.
High sensitive. Is there ever a point where they're equal?
They could be. Like Thomas test is actually pretty equal on both. I think it's like 0.8, 0.8. So 80%, 80%. That's a pretty good test. That means if you do the Thomas test and you get a positive result, you're pretty sure you have hamstring tightness, or not hamstring, quad tightness. And then if you get a negative result, you probably don't have quad tightness.
So what would a question look like if it was?
Yeah, so a question would look like, if it's asking about that, it'll say, which of the following tests would be best to rule a condition in or to confirm a condition, right? Confirm would be rule in, deny would be rule out, right? So confirm, you'd go down and you'd look and there'd be a bunch of numbers down there. It'll say, you know, specificity, percentage, sensitivity percentage. And you're going, if it says to rule it in, you're going down and looking for a one with a high specificity.
Okay.
You don't really care about the sensitivity at that point.
Yep.
Right.
Just highest specificity.
High specificity. Yeah. Now, if it said which of the following tests would be the best overall test, you'd want one with a high specificity and a high sensitivity. Does that make sense?
Oh, okay.
Does that help?
Yeah.
Everyone else pretty cool on that?
Thank you.
Yeah, no problem. All right, so the next one is a neuro one, and I did not make this one as long. I think this one's only 15 questions. So let me present in a new tab. And let me get into it so I can manage it on my phone. And broadcast so you can join me. My chat here again. And we'll fry your brain with the neuro questions last. Ha, ha, ha. I'm so funny. I don't know how you guys put up with me. You know, I love your lemons and limes there. Here's the deal is, you know, what do you say if you get Lyme's disease? Does anyone know? Thanks, dear. That's funny.
Deer ticks?
From deer ticks, yes, exactly. Thanks, dear. I know, I'm ridiculously funny. We'll give a few more seconds here. All right, I'm just going to start it up here. And take a deep breath. Here we go into neuro. Start quiz. Okay. So here, I'm going to give you a clue on this question because there's an easy way you can always answer this question. Anytime you see a spinal cord injury and they're talking preserved tightness, you're always going to go to thinking of what type of a grip we want to preserve. What's that grip called?
Lumbrical grip.
Tenodesis, right? It almost looks kind of lumbrical-like, right? But it's not. The technical term is tenodesis, right? So that means we want the finger flexors to curl up because that way when I extend, I can grab things, right? So anytime you get because whatever the rest of the stuff is, you need to go down and look specifically for preserving tightness in the finger flexors. They're not going to have two answers with finger flexors in, right? Finger flexors is always the answer that you want to. If my fingers contract up, right, my flexors are now tight. If I extend my wrist, my fingers move back even further, and that allows me to grab a hold of things as I'm extending my wrist. And that could be useful for eating utensils or, pretty much anything we would need to grab, right? Any like a washcloth, anything at all. Does that make sense? So always when you get a question that's asking about this, I guarantee the question is asking about tenodesis grip, right? But in general, would we want to pretty much stretch everything else so they don't develop contractures? In general, most times with spinal cord injuries, we want to stretch pretty much everything else. All right. Next question. Okay. Oh, yep. Good. All right. So let's take a look here. Good. Right. So we have right CVA. So that means what side of the body is affected? Left. Good. Right. Correct. I'm going to stop saying right and left. So yes, if I have a right CVA, my left side is affected. Correct. And I've developed pusher syndrome. Right. So that means they're probably pushing over towards that side. Yes. Now, eventually, if they don't get enough therapy, why might they start pushing to the good side? So what does anyone have any ideas? So, right. So you're on the right idea. You're on the right idea there, right? So the main idea there is that if I don't get therapy and start strengthening this side, right, my left side that's affected, I'm going to start ignoring it entirely and I'm going to shut those muscles off. That means the only muscles that are firing would then be my other side. And I'd be starting to compensate and I'll just pull that way, but I have nothing on this side to pull me back. Right. So if you have somebody long-term stroke that's never had therapy, they may long-term get pushers to the other side. But initially, all the questions that are talking about pusher syndrome push towards the affected side. And I threw abbreviations in here very much because I know that Brooke hates abbreviations. Let's see how we did. Okay. So let's think through this really quick. The patient who has T10 paraplegia, what leg muscles do they have? None, pretty much, right? So let's just say that we did go the Lofstrand route. And the Lofstrand, because the Lofstrand's not the right answer, but let's say we did go the Lofstrand route. That's okay. That's okay, Alex. That's why we do this, right? Let's just say the Lofstrand. Then hold on a second, Brooke. Yeah, they're paraplegic and hemiplegic mean different things, right? Hemiplegic means one-sided is paralyzed or non-movable. Paraplegic just means I've lost typically two of my limbs, right? Typically it's gonna be my legs, right? So let's just say that Lofstrands were the right answer. Lofstrands and an orthosis. What else would have to be attached to that orthosis in order for that to be the right orthosis?
The knee.
We have the knee. So we have the knee, ankle, foot orthosis. We'd also have to the hip. Yeah, because they have no strength in the hip. Right? Or the other thing they'd have to say is Lofstrand with reciprocal gait orthosis. That would allow them to be kind of upright. But man, those things are just monsters to get them in. And family's not typically going to do it. So they're going home with a wheelchair at a T10. Right? And honestly, if they go home with a wheelchair, for the most part, they're probably going to go home with an off-the-shelf wheelchair because they're not going to get a custom wheelchair right off the bat. So that means we definitely want to send them home with a pressure relieving cushion. Otherwise, they're going to develop pressure injuries where?
Ischial tubes.
Ischial tubes, and I heard sacrum. Good. In the butt. That's the best way to answer it. Exactly. Somewhere in the butt. Right? They will become the butt of all of those injuries. I'm so funny. I don't know how you guys put up with me. Okay. So we're kind of all over the place on this one. So first of all, what is perseverate mean? What does perseverate mean? Perseverate. So yeah, I can't say it. Shush. Continue repeating something over and over again, right? And what are they likely to perseverate on? Yeah, inappropriate stuff. Yeah, it's not going to be like, I don't know, cinnamon roll. That would be good. It's usually going to be the most inappropriate words you can possibly imagine, right? All the guys I've had ever with that end up stuck on typically 4-letter words. I'm just saying. So let's look at the first answer. Focus on the topic of the perseveration for a short period of time. Why would you not want to do that? Ceiling fans, yeah. Kirsty, yeah, I've had that. Yes, right, it'll influence it. Yeah, if you tell them, hey, we need to stop doing those words, that's really bad. All it's going to do is make it worse. Yeah, right? It's just, think of it almost like a kid at that point. If you tell a kid, stop jumping in that mud puddle, the kid's going to go do what? Go jump in the mud puddle or throw you in it, one of the two, right? So that one's kind of out automatically, right? And just because they're stuck on a word doesn't always mean we want to take them back for quiet time, because at that point, what are we doing to the patient? not even defer, think even further than that. It's like putting them on timeout. Yeah, right? You're putting them on time. Go back to your room, and when you stop saying those bad words, we'll do therapy again. You bad boy. Now, if it had said take the patient back to their room and continue treatment back there, that would be a different answer, right? Because then that could be a possible answer. But this one doesn't say continue treatment, it says resume treatment later or something once they've stopped. For the most part, the problem they're getting stuck on that word or that phrase, like Kirsty said, ceiling fans, those are great too, right? Or they get stuck just staring at them, right? Any of those, that's okay. That's why we talked about this, so I went over it, right? The guiding the patient to something new, especially if we're walking and they're stuck on a word, right? If you know that they've got stuck, if they've already got the perseveration going on, perseveration, whatever, that word, the word I can't perseverate on. If they get a word, they're stuck on, I don't know, Coke. If you give them a new task, stop the gait activity for a little bit and maybe do some math with them, or have them do marching, right? When you give a task, it kind of reorganizes the brain a little bit and it changes them getting stuck on it. It doesn't always fix it, but it does tend to give them a little bit of a thing. And then if you reward them, you are then giving them, yeah, now we know, exactly. You're now giving them incentive to not do that again. And again, almost back to primitive reflexes in kids. Think about kids. If you reward them for doing something right, they're less likely to do something wrong, right? All right, next one. Yeah, that would be a good way of thinking about it, Alex. That'd be a great answer. We'll go over this question in a second, but Alex brought up a really good, so Alex's comment of telling them, let's try to march in place and count each time we complete 2 knee raises. That's actually a really good one, because at that point, Alex, you're integrating a physical activity along with a cognitive activity, and that may help stop that sticking on the words. All right, so patient has a CVA, and if they have right hemiplegia, that means what type of a CVA do they have? Left, good, okay. I just keep repeating that. Good job. So which of the following therapeutic positions should the PT be most difficult? And why would half kneel with the involved leg posteriorly be the most difficult?
Because that's what's holding up your weight.
Yes, that's the pressure. That's the pressure, weight bearing on it, right? Good. Bilateral tall kneeling, bilateral lower extremity bridge, you can fake it because you can use the good leg to provide you with support, right? And same thing with half kneel with the involved leg anteriorly. That means that all your weight bearing is going through your good leg, right? So when you put that bad leg back, and I hate to use the term bad leg, but affected leg would be the better term, right? Because we don't want to use, we want to use patient first language, right? But patients remember a bad leg, I'm just saying, right? Half kneeling with that bad leg back is going to cause them the most difficulty. And if you are going to do half kneeling with the involved leg posteriorly, what should the patient have on? Gait belt, yes, right? ABGB, always be gait belting. Yep, exactly. They never want to use it. Most times, Brooke, most of the patients don't want to use that affected leg at all. And that's why we want to use it, so that hopefully they don't develop neglect on that side, right? All right, next one. They got a mica stroke. Not a mica, mica. All right, let's see where we are. Probably going to be all over the place. Okay. So intention tremor is the best answer here. Right? That's okay. That's okay, Brooke. So let's go over what are the three most common. They're all CAs. So we have ACA, MCA, and PCA, right? Those are the three main common strokes. Which of those is the most common? MCA is the most common. Yes, good. And if you remember, the reason why it's the most common is because it gets all the blood from those internal carotids, which is the easiest way for a blood clot to get to the brain, right? They're contiguous with that internal carotid artery. So let's go with anterior cerebral artery first. Anterior cerebral artery, for the most part, if you remember back when I talked about this, the big thing to remember with that is anterior cerebral artery, you want to remember, is more upper than lower, right? And is going to feed some of the anterior brain. So they're going to have some impulse control and some stuff like that. But the main thing is ACA, upper more than lower, right? Then we get to MCA. MCA is typically lower more than upper. And then also because it helps feed some of the cerebellum and some of those middle parts of the brain, they often get intention tremors.
You said that one's lower more than upper?
Lower more than upper for the MCA, right? And then PCA, posterior cerebral artery, which is kind of the least common of them. That one you're expecting to have what type of problems? Do you remember? Because feeding the back of the brain.
Like bounce?
Vision is the big one. Good, Anthony, right? Vision is the big one, right? So they're going to have vision. And then the other thing that's common with those PCAs is the agnosias. What's agnosia mean again?
Inability to recognize familiar things.
Good. Yes, right. So you could have any of the visual spatial agnosia, prospagnosia, any of those agnosias, right? Tactile agnosias. That's common with PCAs. Yes, agnosia is the right way to spell it. Good, right? So they're more likely. So PCA is vision and agnosia. PCA can also sometimes get a residual or a postural tremor too, but it's kind of unlikely. So the main things, remember, ACA, upper more than lower, right? MCA, lower more than upper with intention tremor. And then PCA, visual stuff, right? Recognizing stuff would be PCA. Does that make sense? Does that help you guys kind of, that's easy 3 ways to remember those. And then if they have a stroke of the basilar artery, are we going to see them? What do you think?
Only if we're working in an ICU or something.
Yeah, right. And primarily, yeah, they're usually expired. Exactly. If they have that basilar stroke, that's pretty bad, right? Because then the pons typically gets knocked out, and then the other dead. I mean, if you're working in maybe a funeral home, you might have to deal with them, but we typically don't do therapy on those people in funeral homes. I'm just saying. All right, what are you confused with? I'm sorry, Brooke, what were you confused with the question? Do you want to go back with that at the end?
Yeah, that's okay. Because it was just intention tremor for MCA, right?
Yes, intention tremor for MCA.
Okay. And it was MCA for the last question?
Yes.
Right?
Yep.
Okay, because it just said everything except.
Oh, did it say accept? I'll go back. I'll go back to it. We'll go back to that one. Maybe I made a mistake on that one. Let me go look at it. It might be my fault. All right, let's go to the next question. We'll come back to that in the end.
Okay, no worries. I'm probably wrong.
I'll look at that then. Thanks, Joe. This was a trick question. Why was this a trick question?
I'm getting this question wrong because of you, Mr. McKeever. So
Yeah.
now I'm not happy.
That's okay, because I added excess instead of missing, right? Because Parkinson's is a disease of dopamine. I just wanted you to read the question a little bit, Riley, not psych you out. Parkinson is a disease of dopamine, right? So they're missing dopamine. And because they're missing dopamine, they have an excess of acetylcholine because they are the two opposed, right? Dopamine controls acetylcholine. And what specific problem do they have that is a good sign that they have an excess of acetylcholine? What symptoms? What's a cardinal symptom of Parkinson's?
Like a resting tremor.
Tremor, yeah, the movements in general, yeah, right? So their tremor, and then also their festination, where they get their little feetsies going like, right? That's a sign of excess acetylcholine. Oh, wait, I didn't realize I had another question about this. Look at that. Ooh, I'm impressed here. I'm impressed. I'm liking this. Oh, not liking it as much now. Oh, okay, coming back. The anterior hemisphere means up here, right? And anytime we have anterior hemisphere problems, the patient is going to be impulsive, right? Now, could this also say right anterior hemispheric damage due to a TBI? And the answer would be the same. Yeah, right. And that left hemiplegia is just there to throw you as a red herring again, because you're all of a sudden thinking, oh, wait, oh, yeah, I got to think about what's going on with their movements, and has nothing to do with the movement at this point. Right? It's just talking my frontal brain damage. My frontal brain damage, that means impulse damage, means they're going to take risky behaviors, right? What might they do to you as a clinician? Lash out. Good, right? They might lash out. They may grab you inappropriately. They may say inappropriate things.
Mr. McKeever, quick question about this one. So for this example, yeah, it threw me off with the left-sided. Because I know right-sided has to deal with like they're more like they act out more, right?
Mm-hmm.
So when we get a question like this, and they had, so when you have a stroke, what side it went on is affecting the right side, but the motor deficits are on the opposite side?
Yes, typically. And honestly, for this question here, Brooke, the right really doesn't even matter. Neither does the left hemiplegia. The only thing that matters is that they have anterior hemispheric damage.
Okay.
Does that make sense? Because if you've got anterior, if you've got front, because that's going to involve some of the frontal lobe. Frontal lobe is impulsivity, right?
Okay.
So frontal lobe impulsivity, right? Communications kind of sits back here behind the ear, right? And kind of up and over the ear. Visual is where?
Occiput.
Posterior.
Posterior, right? And then hesitancy with task recall is more central brain, right? Because that's what part of the brain? It starts, one of the ones that starts with a C. Because if they have hesitancy with task recall, they have apraxia, so cerebrum, right? Because cerebellum's balance, right? But if anterior damage, anytime, whether it says a stroke, whether it's TBI, whatever it is, if they have anterior hemispheric damage, they're going to be impulsive, right? So then if it says like lateral or behind the ears, then we're going to have communication problems, whether hearing because our auditory is damaged or the Broca's and Wernicke's aphasia.
Okay.
If I have posterior damage, vision, right? And then if I have central hemispheric damage, that would be hesitancy with task recall.
Okay, so just that was all stuff that I got caught up in. All right.
Yep. And that was the point of it.
Great.
That's okay. No, I don't. Go away. Don't need you, S word. I don't want to say her name because if I say her name, she'll come back to haunt me. Uh-oh. I may not like this question. Well, depends. Oh, wait. Okay. Never mind. I reread it. Okay. Why is passively correct the least effective? I'll look at that then, Joe. Why would passively be the least effective?
Because we're not initiating the movement.
Yeah, right? Yeah, they're not understanding their movement. They're also not doing anything, right? So anytime that you have like a least effective treatment, if passive is down in that answer, it's probably the best answer, right? So like even for stretching, right? Active stretching is better than just passively stretching the patient because then they become dependent on you for stretching them. Right. So passive would be the best. I initially read my own question wrong. Good job, Mr. McKeever. Okay, so overall good choices. So this is asking, so patient has multiple sclerosis, right? And the first thing you look at and go, uh-oh, multiple sclerosis, I got to think of a cool way of cooling them down. But that's not really what this question is even asking about. And saying they have proprioceptive sensory loss. And it's saying which is not an effective tool, right? In this case, they're saying what would increase their sensation, right? Why would pool therapy increase their sensation?
Because they can feel the water against their limbs.
Yeah, so now they have 360-degree sensation, right? Because they've got the water against their limbs, stuff like that. Light tracking, good. No one picked that one. Visual compensatory treatment would be definitely good for this because, again, if they can see themselves making poor choices, that'll be better. Stretching the spastic muscle groups has nothing to do with that, right? That's just to stretch out. And honestly, if you have a spastic muscle group, what's probably likely to happen if you start stretching it?
Get like clonus?
Could get clonus, could get worse, right? Yeah, so clonus would be ultimately the worst form of spasticity, right? But yeah, exactly. All right, 5 more. All right, so good choices between the two. Why would rhomboids be the best answer here?
Because they're already stretched out.
Because they're already stretched out, right? If I got forward rolled shoulders, my rhomboids are as stretched as they're going to be, right? And again, heel cords would be the second best answer there, but more than likely they're going to be tight too.
I was just thinking, I guess you want to strengthen the rhomboids to correct your posture.
Right. You would want to strengthen them, but not stretch them.
Oh,
Yeah. See, there you go. Yes, the heel cords would be the Achilles tendon and all the associated, and also like the tib post and stuff like that. Right. Soleus, all that good stuff. Yep, exactly, Joe. All right, it's going to go right to the next question because I don't have the leaderboard after this one. It should go to the next question. There we go. I'm going to tell you the key word here is preventative. Oop, I saw some changes. Okay, so that pressure relieving is the only preventative treatment there. The others are what type of treatments for an ALS patient? Does anyone have an idea what they might call those?
Maintenance.
Maintenance. Yeah, there you go. Good. Right. Those would be maintainative or maintenance treatments. Right. So strengthening, obviously, we're going to want to do so they maintain as strong as they could. Endurance, definitely. And then ACBT is definitely one. What's ACBT again?
Active cycle of breathing technique.
Good. Yep. I put that on an abbreviation just to mess you guys up because I know that Brooke really loves abbreviations. And you know that one? Okay. And ALS is obviously, what's the other term for ALS?
Lou Gehrig's.
Lou Gehrig's, good, right? And which way does it progress? So I've got 1 vote for proximal to distal. Do I have any other votes?
Distal to proximal?
Good. ALS is distal to proximal, right? Which one is proximal to distal? Duchenne's. Good. Yes. Right. They're kind of two sides of the same coin in that way only. Right. Is that ALS distal to proximal, right? Because the last thing that goes on them is their core, their breathing ability, right? Versus Duchenne's, the main thing that goes first is their belly, right? They lose all that ability to contract their stomach because it turns basically to jello, essentially. And just real quick, since we're on the topic of Duchenne's, what is the common sign for Duchenne's that you might see in kids? Gowers, good. See, you guys do know stuff. Gower sign, what's that look like?
Like coming up from your knee.
Yeah, so you use your arms to get you to sit up straight, right? They can't get up. Good. Good job, guys. Stop saying a few things. You guys, look how well you did today so far. Oh boy. Come on, guys. Come on, guys. Come on, buddy. Okay, most of you didn't get tricked on this one. So individuals with ALS are at risk to develop all of the following shoulder pathologies and weaknesses, weakness progress, except, right? The first three are all shoulder pathologies. Acetabular fragility is not a shoulder pathology. That's a pathology of the hip. Yeah. Right? I was tricksy hobbits there. I was totally messing with you a little bit there. That's okay. Come on, go forward. All right, 2 more questions. All right, so what is your key word in this question?
Relax.
Relax. Good, right? Relax is your key word. And rhythmic initiation in PNF is another term for what? PROM. Good, passive range of motion. And if they're doing passive range of motion, the word you use to them is just relax and let me do the work, right? Let me move you through the motion. Alternating isometrics. Do you remember what that one is? Why would that not be a relax? Because they're doing a contraction. Good, it's even in the word there, right? But remember, alternating isometrics means they're moving in a linear pattern, right? Whatever joint you're working on, whatever you're working on core, you're working on the shoulder, you're working on the wrist, whatever it is with alternating isometrics, you're moving in a line, right? Rhythmic stabilization is the progression of alternating isometrics because now you move from just doing a line to kind of perturbating them everywhere. And then hold, relax, stretching, while there is a relax in that, the hold, they're doing a what?
Contraction.
Contraction. What type of contraction?
Isometric.
Isometric. Good, right? Contract, relax, they would be doing what type of a contraction?
Isotonic.
Yes, an isotonic, right? Typically a concentric, right? Contraction. Good. Good, good, good. Uno más. And I save the worst for last. All right. Good. Right. So VOR, what does VOR stand for, first of all?
Vestibular ocular, or reflex.
There you go. Yes, vestibular ocular reflex. So integrating the vestibular with the vision, right? So VOR1 paradigm, which is the VOR1 exercise, the head moves while maintaining focus on a static object. Is vestibular patient exercise. Good, Alex, right? So what I could tell me is I could say, okay, Mr. McKeever, I'm going to put that Coke can in front of you. Focus on that Coke can and move your head back and forth. Right? And I'm just going to focus on it and try to keep it from going blurry. Right? What would be VOR2? Do you remember VOR2?
Is that where the head moves in the opposite direction of the object?
Yes, the head moves in the opposite direction of the object, right? So I'm moving, okay, here. I'm trying to move back a little bit. There we go. Good, right? VOR2, right? Good, good, good. Let's see what we got here. So even that one, not bad, guys. I know you guys love vestibular, and I know you guys love neuro. Stop. I don't like to see those words. Doesn't matter if you did or not. Stop. Don't use those words. You don't like neuro either. So it is what it is. Let me go back here really quick. Give me 1 second. I'm going to take a look at the thing Joe sent me real quick. And see if I screwed up. It's quite possible, Joe, that I might have screwed up. I've been doing 3,000 things, so I'm not going to put myself as completely innocent here. So let me take a look real quick. Give me 1 second. I need to get to my PowerPoint here on this. I think where I was going. My brain working no good. Okay. There's quite a possibility, Joe, that I screwed up, and if that's the case, I'll absolutely own making a mistake.
Yeah, I was just trying to make sure that.
Nope, that's fine. Yeah, no, I
know.
want to make. I just want to make sure I didn't screw up, and how I know I didn't. How I would know if I did screw up or didn't screw up is by bringing up my own PowerPoint on it, because that'll help me clear my own brain. I mean, it's possible. It's not like I'm perfect. I try to be, but I'm just not always perfect. Just saying. You guys may think it, and you may think I'm amazing, but sometimes I make mistakes. I know. It's crazy. There we go. I just want to make sure that I didn't make a mistake, and or if I have to talk to her from, because my slides come from the, oh yeah, I did screw up, Joe. Thank you. So let me correct this. Joe called me out and I appreciate it. Yep, I'm going to openly admit this. I screwed up, guys. I had my brain all messed up. Sorry, I had a stroke. So let me go back and correct this really quick, please. Anterior cerebral artery syndrome, lower extremities more than upper extremities. And urinary incontinence goes with it, but that's beside the point. Middle cerebral artery, upper more than lower. And then posterior is visual still. That I didn't mess that up. I just switched up MCA and ACA. It happens sometimes. I get stuck in my own brain. Yeah. So her slide is correct, Joe. I got my brain twisted a little bit there. So don't totally worry about that. So again, with that, and that is a good picture she sent. I just totally botched it, which is, hey, par for the course occasionally. I'm going to blame it on the fact that, yes, ACA lower than up. Yes, Anthony, you have it typed out right there. Yes. And I'm just going to blame this on the fact that I'm overwhelmed being a program director as well as teaching. We're just going to blame it on that. That's my answer for that. I'm just going to stick with that. That's my answer and I'm sticking to it. I don't care what you guys say. But yes, that is correct. And I want to go back and look at that question because Brooke said I might have screwed that question up. So let me go back and look at that real quick. I mean, it's quite possible, but I don't think I did. Let me go back. I was already logged in. Why did you make me log in again, you stupid system?
Mr. McKeever, are we going to go over anything else?
Not really. If you need to go ahead.
Okay. Thank you.
Thank you. Yep. Is there any other questions while I go back to this really quick? Well, if you have any other questions, let me. Yeah. So Brooke, you're right. The reason I got messed up is because I got ACA and MCA screwed up. That was, yeah, I was thinking that ACA had, yeah, totally just flipped the stroke levels. Sorry, I apologize about that, Brooke. Occasionally I make a mistake.
So it wouldn't, the right question, it wouldn't have been intention tremor because that goes along with MCA.
Well, no, intention. So I was messed up when I was talking about it there. Intention tremor does go with ACA. I got messed up when I was answering the question to you, is what I'm saying. Right? So intention tremor goes with ACA, not with MCA.
Okay.
MCA would be postural tremor. If you have it.
Postural tremor?
Yeah. Because again, MCA is going to affect more of the cerebellum.
Okay.
And so Anthony asked, can you tell me where exactly does the cauda equina end? Usually where the spine does. I'm just messing with you. So where does the cauda equina end? You guys remember that from way back when? I know he's like, well, that's what I just asked you, Mr. McKeever. But I got to mess with you a little bit.
Is it like S1?
Okay. So let me.
Medullaris is L1.
Okay. So let me get down here. So cauda equina typically, right, terminates at the, what is the point of termination called where it terminates at? The cauda equina terminates in the conus medullaris, right? Okay, so yes, you still have the filum terminale. Anthony, the filum terminale is just that tether that holds the cord to the actual bone. That's a part of your actual meninges, right? So the cauda equina, in essence, really, I mean, it ends somewhere around like L1, L2, L3 is typically what we talk, or well, no, actually L1, L2 is kind of the end of the spinal cord cauda equina. Let's go this way. Anthony, what answer, what reference are you asking this question? Maybe that'll help me clarify this a little bit. Is there a question on that you had? Because in reality, the cauda equina ends in the nerve roots. When I was actually starting to think kind of about it, the cauda equina is kind of, that's okay. The cauda equina is where everything kind of goes out from there and it goes out to the nerve roots. So really ending, it ends in the nerve roots and the plexes. Yeah. Upper and lower cauda. I would not prepare yourself too heavily on that, Anthony. That's all I'm going to say. The likelihood of getting a difference between upper and lower cauda equina lesions is pretty low, but you're more likely to get a question on cauda equina syndrome. And what are the signs of cauda equina syndrome?
Is
Minus gait.
Hold on a sec. Two people say at the same time. Let's go with Joe first.
Quinus gait, or I don't know that word, that horse gait.
No, not horse gait. That has to do with more the plantar flexors, right?
Is it the saddle paresthesia?
Saddle paresthesia is the big one. Good, right? That's the sensation on the inside of the legs being numb, right? And then bowel and bladder loss. Right? So Anthony, if I'm really worried about, because honestly, I would not focus heavily on going, what's the difference between an upper and a lower cauda equina lesion? I just more focus on what does cauda equina syndrome look like? And knowing that that's a medical emergency, right? They need to get in within 48 hours. Or otherwise those symptoms could become what?
Permanent.
Lethal?
Permanent, yeah. Well, not necessarily, maybe lethal eventually if you get an infection, yeah. Did I fry your brain a little bit? Brooke looks like she's fried a little bit. You guys did really well today. I mean, if you average your scores together, like if you average your neuro score along with your musculoskeletal, I bet you're over 60%. And again, remember for the boards, you know, I know it sounds bad, but 67% is a 600. Right? I know everyone wants to get 100. Brooks is like, I need to get 99.95%. Right? But you need to get a 600. That's all you have to get.
TJ and I were talking about that, I think, the other day, and we were wondering how many questions is it again that you need to get right?
About 97. So you can get about 53 wrong is kind of the range of it. Right? Yep, no problem, Brooke. Are there any other questions for today? I know I fried your brains. If not, go forth and enjoy your Memorial Day weekend.
I have one quick question. I was going over the special test for Allen's. It's the arm down in abduction and slight extension looking away, right?
So, yeah, so which one is towards?
Adson's.
Good. Adson's is towards, Allen's is away. Good.
Okay.
Yep.
Yeah, 'cause I was looking it up online and they were showing something completely different that wasn't right.
Yeah, just remember, for the most part, those tests are the same. It's just the direction of the head.
Think of Adson. Adson is towards the PT, right?
Yeah.
Yeah, I was more talking about the arm position. It's down below, right?
Mm-hmm. Yeah. Arm position overall is the same, though, in general for it. All right. If there's no other questions, please go forth and enjoy your weekend, please. Have a happy Memorial Day. Have a little cookout with your family, maybe. Get out of here. I'm going to stop recording.